Heart disease is the #1 cause of death in both men and women globally. It claims more lives than all forms of cancer combined. Cardiac arrest is always a medical emergency, and it can affect all ages, genders, nationalities, and races. In cardiac arrest, blood stops flowing to the brain and other vital organs. Cardiac arrest is most often caused by a cardiac issue in adults and respiratory issues in children and infants. Cardiac arrest is often fatal if the appropriate interventions are not taken immediately. This is why early recognition and immediate cardiopulmonary resuscitation, or CPR, are crucial for survival. Basic life support, or BLS, including CPR, is the foundation for saving lives after a cardiac arrest. Advanced rescue measures cannot be successful on their own without high-quality BLS skills. Healthcare professionals are the backbone of the systems of care in both the in-hospital and out-of-hospital settings. In this course, we'll review the BLS skills you have learned previously, and you'll have a chance to practice those skills along with the practice while watching videos.
Approximately 960 people have a cardiac arrest each day in the United States. With the training you receive in this course, your actions can give a person the best chance of survival. High-quality CPR and defibrillation can double or even triple the chance of survival for someone in cardiac arrest. For every minute that passes before someone takes these life-saving actions, the person's chance of survival decreases by about 10%. Cardiac arrest can occur without warning or within just a few minutes after symptoms appear. The term heart attack is sometimes mistakenly used to describe cardiac arrest. Although a heart attack may lead to a cardiac arrest and sudden death, they are different conditions. A heart attack occurs when a blood clot blocks oxygen-rich blood from reaching the heart. When this happens, the heart muscle starts to die of hypoxia, or a lack of oxygen. As a result, cardiac output decreases because the heart can't pump enough blood throughout the body. In cardiac arrest, the heart stops beating and no longer pumps blood or oxygen to the body's vital organs. A heart attack can lead to cardiac arrest. Cardiac arrest can also happen because of an arrhythmia or an electrical issue within the heart. Other causes can be severe blood loss, breathing issues, drowning, drug overdose, severe allergic reactions, or a traumatic injury such as commotio cordis. Commotio cordis is a rare cause of cardiac arrest that can happen after someone is struck in the chest by an object, like a ball, a puck, or another person during a specific point in the heart's rhythm cycle. It's more common in young people, likely because of their thinner, less developed chest walls. In a small number of cases, commotio cordis is caused by other types of physical trauma, such as a car accident or an assault. No matter the cause, the signs of cardiac arrest are the same. Cardiac arrest may start with someone collapsing, followed by a lack of responsiveness and no breathing, pulse, or heartbeat. Your provider manual includes more information on the differences between a heart attack and cardiac arrest. Despite these differences, it's critical that rescuers follow the chain of survival for both conditions to give the person the best chance of survival. Each link in the chain of survival represents the important interventions applicable to adults, children, and infants, both in and out of the hospital. The links include recognition and emergency activation, high-quality CPR, defibrillation, advanced resuscitation, post-cardiac arrest care, and recovery and survivorship. There is a separate chain of care for newborns because they require different interventions. The links include prevention, recognition and activation, initial steps, ventilation, advanced resuscitation, postnatal care, and recovery. Watch as we take you through the chain of survival in the following scenario. These university tennis players are practicing for their upcoming championship game when a player suddenly collapses. First, the athletic trainer assesses the scene quickly to make sure it's safe.
Are you okay? Are you okay? You call 911 and get an AED.
He doesn't respond, he's not breathing normally, and he doesn't have a pulse. It's important to note that abnormal breaths, called agonal gasps, are common in the first few minutes of a cardiac arrest. Rescuers can sometimes mistake agonal breathing for normal breathing and fail to recognize cardiac arrest and initiate CPR. Agonal breathing may sound like a gasp, snort, snore, or groan. Seizure-like activity can also occur with cardiac arrest. If the person is not responsive and not breathing normally, you should start CPR. We recommend that all locations and organizations have a cardiac emergency response plan in place, which outlines specifically who responds and what to do in a cardiac emergency. In the scenario you just watched, you saw the chain of survival in action, as the athletic trainer assessed the situation and recognized a possible cardiac arrest. She activated the emergency response system and told someone to get the AED, or automated external defibrillator. The athletic trainer then immediately starts CPR. Be aware that both lay rescuers and trained rescuers who are not comfortable providing breaths may provide compression-only CPR, also called hands-only CPR. Trained rescuers like you might find it necessary to provide compression-only CPR until a barrier device, pocket mask, or bag mask device is available. But giving breaths is especially important for infants and children because respiratory distress is a common cause of cardiac arrest for these age groups. You may interact with lay rescuers who have started hands-only CPR when they see a teen or adult collapse suddenly. Lay rescuers are encouraged to follow 2 simple steps for hands-only CPR. Call 911 and push hard and fast in the center of the chest. The 911 telecommunicator may provide further instructions, including step-by-step coaching on how to perform CPR until emergency responders arrive. Defibrillation with an AED is the next link in the chain of survival. You can use an AED on anyone in cardiac arrest, even an infant, a child, or a pregnant person. Most cardiac arrests are triggered by abnormal heart rhythms called arrhythmias. The most common and treatable arrhythmias that cause cardiac arrest include ventricular fibrillation and pulseless ventricular tachycardia. With ventricular fibrillation, the heart's electrical impulses suddenly become chaotic and ineffective. Blood flow to the brain and other vital organs stops abruptly, and the person loses consciousness. In pulseless ventricular tachycardia, the heart contracts too fast, preventing the ventricles from filling with blood, and eventually blood flow to the body stops. Without blood flow, a person has no pulse. Both ventricular fibrillation and pulseless ventricular tachycardia require CPR until an AED is available. In both rhythms, death usually follows unless a normal heart rhythm and pulse are restored within minutes. An AED is used to treat cardiac arrest. The AED works by analyzing a person's heart rhythm and delivering an electrical shock to the heart if needed. The shock resets the heart's rhythm, causing it to start pumping blood to the brain and to the rest of the body again. This may sound scary, but an AED will not deliver a shock unless one is needed. The AED is easy to use. All you have to do is turn it on and follow the prompts. We will learn more about how to use an AED later in the course. Rescuers trained in advanced resuscitation provide more advanced treatment, such as giving medications or performing advanced airway interventions. Advanced resuscitation builds on the foundation of basic life support, extending the chain of survival and giving the person the best chance of survival. Once the return of spontaneous circulation is achieved, the person receives post-cardiac arrest care. Post-cardiac arrest care after return of spontaneous circulation focuses on preventing the recurrence of cardiac arrest and improving long-term survival. Recovery and survivorship from cardiac arrest continues long after hospital discharge and includes physical, emotional, and ongoing support. These links in the chain of survival outline the most important interventions to treat cardiac arrest. Your ability to provide high-quality BLS can help save a life. Now, we'll focus on the individual skills that rescuers perform during BLS. It's most effective to perform CPR as a team, but to be an effective team member, You'll need to learn the skills of CPR first.
Now, let's practice one rescuer adult BLS. Follow along with the video as we check for scene safety, assess the patient, and activate the emergency response system. Then, you'll perform 5 sets of 30 compressions and 2 breaths with a pocket mask. Be sure the chest rises with each breath, but remember, provide breaths with just enough force to produce visible chest rise. Limit interruptions in chest compressions to no more than 10 seconds while you give breaths. Here we go. In 3, 2, 1. Check for scene safety.
Hey, are you okay? Are you okay? Help! Somebody help me! Activate the emergency response system and get the AED. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Next, we'll learn about how to use a bag mask device to provide ventilation when one is available. Bag mask devices consist of a ventilation bag and a face mask, and they come in a variety of sizes. You can use supplemental oxygen with a bag mask device. First, select a mask that's the appropriate size. The mask must cover the person's mouth and nose completely, without covering the eyes or extending below the bottom edge of the chin. If you are trained to use one, consider using an airway adjunct, such as an oropharyngeal airway, or OPA, or nasopharyngeal airway, or NPA, if one is available. OPAs and NPAs can be used by a trained professional to maintain a patent airway and facilitate appropriate ventilation by preventing the tongue from occluding the airway. Next, you'll position yourself directly above the person's head. You'll use the EC clamp technique to hold the mask in place. To do this, apply the mask by first placing the cushion at the narrow end of the mask onto the bridge of the person's nose. Then, lower the mask fully onto the face, watching for the cushion to bulge as it initially seals against the face. Next, form a C with the thumb and index finger of one hand and press down on the dome of the mask toward the face to further seal the rim of the mask. The remaining 3 fingers of that same hand should form an E to reach past the edge of the mask, along the bony rim of the jaw. To tilt the head back, lift the jaw toward the mask and open the airway. Make sure you squeeze the mask with your thumb and index finger while lifting the jaw to achieve an airtight seal between the mask and the face. Then, squeeze the bag with your other hand. If the chest doesn't rise with each ventilation, you're not providing adequate ventilation. If you don't get chest rise, readjust the mask, reposition the head and neck, and try to ventilate again. And then, only if necessary, administer a larger amount of air, just enough to get chest rise. Be sure not to provide excessive ventilation. This could cause gastric inflation, which is air going into the person's stomach instead of the lungs. Gastric inflation can cause vomiting and possible aspiration. Similar to providing breaths with a barrier device or a pocket mask, you'll do cycles of 30 compressions followed by 2 ventilations with a bag mask device. Give each ventilation for 1 second with just enough volume to make the chest rise. If you have multiple rescuers, the most effective way to ventilate with a bag mask device is to use the 2-person bag mask device technique. This means that 2 people will be at the person's head to ventilate. 1 person will focus on keeping the airway open and securing the mask, while the second person squeezes the bag to deliver ventilations. The first person will use both hands to seal the mask to the person's face and lift the jaw. The thumbs and index fingers of both hands each form a C to seal the mask against the face. And the 3 remaining fingers of each hand will form an E for lifting both sides of the jaw into the mask. Be careful not to press too hard on the mask, which could push the jaw down and block the airway. The second person will squeeze the bag to deliver ventilations. Research suggests that some rescuers are less confident and less effective when using a bag mask device on their own. Because using a bag mask device is such an important skill, we'll practice using one next. By this point in the resuscitation effort, additional rescuers may be available to assist you. Additional rescuers can help with ventilation and the AED while you continue performing compressions. If you're tired from performing compressions, you should switch out compressors. Additional rescuers can also help by removing the headboard of the bed so it's not an obstacle during ventilation, bringing a step stool for the rescuer performing compressions, or by placing a CPR backboard. CPR backboards can be used when a patient is on a sofa, bed, or similar soft surface, but don't delay compressions if you don't have one. Quickly position the CPR backboard so that it's centered under the person's back while you make sure to minimize interruptions in chest compressions. It's important to be familiar with the AED in your clinical area. Although AEDs may differ slightly, the actions you will perform are very similar, no matter what AED you're using. To begin, turn on the AED using the on or power button. Some devices will power on automatically when you open the lid. The AED will instruct you what to do once it's turned on. Listen carefully to your device and follow your device's prompts for the next steps.
18, 19, 20, 21,
Apply
22,
pads
23,
to patient's
24,
bare chest.
25, 26, 27, 28, 29,
AED
30.
pads must be placed on bare skin to work, so remove any clothes that interfere with placement of the pads. Place 1 pad vertically on the person's right upper chest. The top of the pad should be just under the clavicle.
1, 2,
Place the
3,
second pad
4,
horizontally
5,
on the
6,
person's left
7,
lateral
8,
ribs.
9, 10.
The middle of the pad should be below the axilla at the mid-axillary line. Ensure the pads are not touching each other. Follow the diagrams on the pads you're using to help you place the pads correctly. The AED may include sets of different sized pads. The larger pads are for anyone 8 years or older, and the smaller pads are for children younger than 8 years. If you're not sure of the person's age or you don't have pediatric pads, use the adult pads. You may need to place the pads in an antero-posterior placement, especially on a child's or infant's chest so they don't touch or overlap. If you're using an AED on a child or an infant, use the child setting. Or if a pediatric attenuator is available, use it. A pediatric attenuator, when attached to the AED, decreases the shock dose. If an infant needs defibrillation, A manual defibrillator is preferred. This device is quite different from an AED, and it requires special training that's not included in this course. If a manual defibrillator isn't available, an AED with a pediatric dose attenuator is preferred. But if neither are available, you may use an AED with pediatric pads without a pediatric dose attenuator. You may need to plug in the pads connector if the pads aren't already connected.
11,
Plug in
12,
pads
13,
connector.
14, 15.
Some AEDs will tell you to press a button on the device to analyze the heart rhythm. Others will analyze the rhythm automatically.
Analyzing heart rhythm. Do not touch the patient.
The rescuer operating the AED is responsible for shouting, "Clear," during rhythm analysis and again before pressing the shock button, if advised.
Clear.
While the AED is analyzing the heart rhythm, the compressor could switch roles with another rescuer if needed. We will cover switching compressors in more detail later in the team dynamics section of the course. If a shock is advised, the AED will charge before you can press the shock button.
Shock advised. Charging. Stay clear of patient.
Check visually to be sure that all rescuers, including lay rescuers, hear the prompt and follow it, even the person giving breaths. Shout, "Clear," and make sure that no one is touching the person before you press the shock button.
Deliver shock now. Press the shock button now.
Clear.
Shock delivered. Start CPR.
After the shock is given,
2, 3,
resume chest
4,
compressions
5,
immediately.
6, 7, 8, 9, 10, 11.
Good compressions.
12, 13,
We can switch when you
14,
get
15,
tired.
16. Okay, 17, 18.
Delivering a shock may produce a sudden contraction in the person's chest muscles. Don't remove the AED or turn it off. The device will repeat the analyze and shock cycle about every 2 minutes, which is approximately 5 cycles of 30 chest compressions and 2 breaths. If at any time the AED indicates that no shock is advised, immediately resume cycles of 30 chest compressions and 2 breaths until prompted by the AED or additional emergency responders arrive. You'll need to consider a few special situations when using an AED. Before pad placement, remove all clothing and jewelry from the chest and apply the AED pads to the bare skin. If chest hair is preventing the pads from sticking, you may quickly shave the area if a razor is available. If a razor is not available and you have 2 sets of adult pads, apply 1 set of pads to the hairy chest. If the chest hair prevents the pads from contacting the skin, the AED will tell you to check the pads. If it does, press the pads down more firmly. If they still aren't sticking, rip the pads off forcefully, removing the chest hair. Then, apply a new set of pads to the bare skin. Excessive sweat or water on the person's chest can also be a problem. It could allow the shock to travel through the water between the pads, ultimately preventing delivery of an effective shock dose to the person's heart. If the chest is covered with water or sweat, wipe the liquid off before attaching the AED pads. Wipe the chest quickly. It doesn't have to be completely dry. If the person is in water, quickly move them to a dry area before using an AED. But if the person is lying on snow or in a small puddle, you can still use the AED. Some people have an implanted pacemaker or defibrillator in the same place where you would put the AED pads. These devices look like a round or square lump that's smaller than a deck of cards. If you see this lump, avoid putting an AED pad directly over it. Instead, place the AED pad to the side of it. Do not place AED pads on top of a dressing, a medical device, or a medication patch. If you notice one of these items, place the AED pad next to it, making sure the pad is not touching it. Lastly, AED kits may include additional emergency equipment such as scissors, razors, wipes, gloves, and a barrier device such as a pocket mask. These items may also be found in a separate emergency or first aid kit. You should familiarize yourself with the AED in your workplace and follow the manufacturer's instructions. Regardless of the type of AED, remember to turn it on first and follow the audible prompts that will lead you through the rest of the steps. We'll pause here to allow you to get familiar with the AED in your class. Your instructor will show you all that's included in the kit and demonstrate the correct way to place the pads on a patient.
Professionals, a two-person or team rescue is a more common occurrence.
How's your homework going?
It's good. Just math.
I don't feel so good.
Mom? Mom! Are you okay? Are you okay?
She isn't responding or breathing. The daughter calls 911 and puts her cell phone on speaker mode.
My mom collapsed. She's not waking up.
The 911 telecommunicator instructs the daughter to start hands-only CPR until Emergency Medical Services, or EMS, arrives. EMS arrives and verifies scene safety.
Miss, we're here to help.
I don't know what happened. My mom collapsed, so I called 911 and started CPR.
They confirm that the mom is unresponsive, not breathing normally, and doesn't have a pulse.
She's in cardiac arrest.
Send additional personnel for confirmed cardiac arrest.
The first rescuer takes over CPR immediately, while rescuer 2 sets up the monitor defibrillator.
Apply pads to patient's bare chest.
Turning on the monitor defibrillator and attaching the pads should occur while compressions are being performed to limit the pauses in compressions. It's important to count out loud while delivering chest compressions so that the second rescuer knows where you are in the CPR sequence.
17, 18, 19, 20.
Plug in pads connector. Do not touch the patient. Analyzing heart rhythm.
Clear.
The monitor defibrillator is now analyzing the person's heart rhythm and will advise if a shock is needed.
Shock advised. Charging. Stay clear of patient.
Clear.
Make sure that no one is touching the patient before the shock button is pressed.
Deliver shock now. Press the shock button now. Shock delivered. Start CPR.
The airway person should provide feedback to the compressor to ensure that chest compressions are provided at the correct rate and depth, and that there is complete chest recoil between compressions. The airway person should position themselves at the head of the patient. Remember to watch for chest rise with each ventilation and avoid excessive ventilation. The compressor should pause compressions while ventilations are being administered until an advanced airway is inserted and secured. We'll talk about advanced airways in more detail later. Plan to switch roles as the compressor every 2 minutes or sooner if the compressor is fatigued. That's about 5 cycles of 30 compressions and 2 ventilations. Switching roles should take no more than 5 seconds to minimize the interruptions in chest compressions. We'll learn more about how to effectively switch roles in the team dynamics section of the course. You may be on a team with rescuers who are trained in advanced life support. However, no matter the skill, procedure, or equipment used in a resuscitation event, BLS is the foundation of all resuscitation attempts. Effective team dynamics increase the chances of a successful resuscitation. Everyone on the team must understand not just what to do in a resuscitation attempt, but how to communicate and perform effectively as part of a multi-rescuer team. Where people and resources are more readily accessible, the real challenge becomes the coordination of rescuers and resources when there are a lot of people involved. Successful teams not only have medical expertise and mastery of resuscitation skills, but they also practice good communication skills and adhere to the key elements of effective team dynamics. Let's watch the following example of good team dynamics so that you can see how an effective team works together during BLS. We understand that real-life scenarios may be more chaotic and don't always run as smoothly as demonstrated in this next video, but it's important to effectively communicate and work together for the best outcomes for your patients.
Okay, everyone, EMS just called in and said they have a 40-year-old male patient who is in cardiac arrest. Pamela is meeting them in the ambulance bay. She'll be in charge of the airway and ventilations when the patient arrives. James and Aaron, can you two alternate performing chest compressions and using the monitor defibrillator? James, you'll perform chest compressions first, and Aaron, I'll need you to manage the monitor defibrillator.
Yeah, I'll start in compressions.
I'll manage the monitor defibrillator and be the CPR coach.
Lawrence, can you take IV and meds?
Yes, I'll take IV and meds.
Kayla, can you record?
I'll record. Great.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21,
Hi,
22,
we are a
23,
BLS crew
24,
here with a 40-year-old male who arrested at home. Return of spontaneous circulation was achieved. The patient arrested again while in transport to the hospital. We started CPR and gave one shock with no return of spontaneous circulation.
Okay, thank you. Let's move him over at 30.
15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
All right, let's move in 1, 2, 3. Okay, I'll take over compressions. 1, 2, 3, 4.
Good switch. James and Aaron, you can swap out compressions every 2 minutes or sooner if you get tired.
Okay, 16.
I'm
17,
recording.
18, 19, 20, 21.
Good
22,
compressions.
23, 24.
Plug-in
25,
pads
26,
connector.
27, 28, 29, 30.
Let's break down the example we just saw. Team dynamics is an element of high-performance teams and can be broken down into 3 categories: roles and responsibilities, communication, and debriefing. First, defining clear roles and responsibilities for the team is important. Every second matters during a resuscitation. Clear roles and responsibilities should be immediately established by the team leader or the first rescuer on the scene. Most often, the team leader will delegate tasks on the basis of each team member's skill level. A resuscitation attempt goes more smoothly when all team members know their roles and responsibilities. Often, the team leader will be at the patient's feet. However, the team leader may need to move around to observe and evaluate the skills of the team and provide feedback when needed. They may also assume responsibility for roles not defined. For the purposes of this video, we'll focus on the roles and responsibilities of BLS, which include the compressor, airway, monitor defibrillator, CPR coach, and the timer recorder. The compressor assesses the person and performs chest compressions. When giving compressions, rescuers should switch compressors after every 5 cycles of 30 compressions and 2 breaths, which is about every 2 minutes, or sooner if they become tired. The rescuer who maintains the airway should be positioned by the person's head. They are responsible for opening the airway and delivering breaths with a barrier device, pocket mask, or bag mask device. The airway person should watch for chest rise and avoid excessive ventilation. The rescuer assigned to the monitor defibrillator, or AED, is responsible for bringing and operating the device. They should be positioned next to the device, follow the prompts, and ensure that all team members are clear of the patient before delivering a shock if one is needed. When a monitor is present, its screen should be positioned so that other team members can see it. Be sure to establish a CPR coach early in the resuscitation attempt. Studies have shown that resuscitation teams with a CPR coach perform higher quality CPR with shorter pauses and compressions. The CPR coach's main responsibilities are to help team members provide high-quality CPR and minimize pauses and compressions. The CPR coach gives feedback about performance of compression depth, rate, and chest recoil. They should also give feedback on ventilation, including the rate and volume of the breaths given. The CPR coach can also adjust the environment to help ensure high-quality CPR. They can lower the side rails of the bed or stretcher, get a step stool, or roll the person to place a backboard and pads. The CPR coach needs a direct line of sight to the compressor, so they should stand next to the monitor defibrillator. The monitor defibrillator role could serve as the CPR coach. Finally, the timer recorder keeps a record of the events that occur, including frequency and duration of interruptions in chest compressions, time of shock delivery, and medications administered. Remember, medication administration is not a part of BLS, and it should be done by an advanced provider during a resuscitation attempt. The timer recorder also announces when interventions are due. When only 2 rescuers are present, they typically take on the roles of compressor and airway, with one of them also covering the monitor defibrillator and team leader. If 3 rescuers are present, they take positions around the patient in the 3 critical roles: compressor, airway, and monitor defibrillator. Every member of the team should know their limitations. Team members should ask for assistance and advice early, not when the situation deteriorates. Anyone on the team should speak up to stop someone else from making a mistake, regardless of role. The next part of team dynamics is communication. Knowledge sharing and summarizing information are critical components of effective team dynamics. It helps to ensure that everyone fully understands the situation. It can also help the team treat patients more efficiently and effectively. Team leaders should review what's happened and ask for ideas and observations from team members. Effective teams use closed-loop communication, the process of verifying that the message sent was received as intended. It's used to prevent misunderstandings and treatment errors. The sender gives the message, the receiver repeats it back, and the sender then confirms that the message was heard correctly. Closed-loop communication verifies that any assigned tasks have been completed. Teams should give clear messages to help prevent misunderstandings and keep everyone focused. All team members should use clear, concise language, speak loudly enough to be heard, and speak in a tone that is both calm and confident. Teams need to communicate with respect. Speak to each other in a professional manner, regardless of scope of practice or expertise. Resuscitation events are stressful, and emotions can run high. Understand that this is the nature of resuscitation, and remain focused on the life you're trying to save. The last part of team dynamics is debriefing. Debriefing allows the team to discuss how the resuscitation went, identify why the team took certain actions, and discuss whether anything can be improved in future events. Debriefing has been shown to help individual team members perform better and aid in identifying system strengths and deficiencies. Debriefing can occur immediately with the entire team or be scheduled at a later time with the team and others. It's an opportunity for education, quality improvement, and processing of emotions after participation in a stressful event. Resuscitations can be traumatic for even the most experienced healthcare professionals. If you find yourself replaying the events, questioning your role in the resuscitation, feeling sad or angry, or not sleeping, these can be signs of post-traumatic stress reactions. Make sure you ask for help immediately so that a professional can help you process what you have experienced and what you are feeling. A high-performing team achieves specific performance metrics, including a high chest compression fraction, or CCF. CCF is the proportion of time during a resuscitation attempt when the person is receiving high-quality chest compressions. You can only achieve a high CCF by eliminating pauses during high-quality CPR. The higher the CCF, the more likely the chance of survival. Targeting a high CCF of at least 60% is recommended, and a goal of 80% is often achievable with good teamwork. Research shows that a 10% increase in CCF is roughly equal to an 11% increase in survival. Pauses typically occur during intubation, rhythm analysis, pulse checks, compressor switches, and defibrillation. We'll address some best practices for minimizing pauses in some of these areas. But you'll also need to measure metrics for high-quality CPR at your own place of practice to identify other areas where pauses exist. You cannot improve what you do not measure.
1, 2.
Whenever compressions are paused, be prepared to immediately resume compressions.
The next time the monitor defibrillator analyzes, let's switch.
Okay, I'll take over compressions then.
If a compressor needs to switch because of fatigue, coordinate the switch to happen as fluidly as possible, such as while delivering ventilations or during a heart rhythm analysis. When switching compressors, the second compressor should take over on the same side as the initial compressor. For seamless transitions, switching between cycles every 2 minutes is best.
1, 2, 3.
It's best practice to use real-time feedback devices during CPR.
Good compressions. We can switch when you get tired.
However, if a feedback device isn't available, a metronome can help establish the proper rate.
47.
If your AED or defibrillator doesn't have a metronome, you can download a metronome app to your mobile device before the conclusion of this course. It's not enough to know what to do or even how to do it. To obtain the best results, your team must perform both the what and the how with high effectiveness. That requires practice, and effective practice requires measurement. But measurement is only effective if you debrief the team, set goals to improve, and practice more. Again, you cannot improve what you do not measure.
Because most cardiac arrests happen at home or in a public place and not at work, you may not have access to a barrier device, pocket mask, or bag mask device during CPR. If you are willing and able, you might consider giving mouth-to-mouth breaths, especially with infants and children or someone you know. Although we won't practice this, it may be a skill you'll need to use one day. Mouth-to-mouth breathing is a quick and effective way to provide oxygen to a person. Each inhaled breath you take contains about 21% oxygen. When you provide mouth-to-mouth breaths, each exhaled breath contains about 17% oxygen. This is why mouth-to-mouth breaths are effective in providing oxygen. Let's go through the steps to deliver mouth-to-mouth breaths. Start by holding the person's airway open with the head tilt chin lift maneuver. With the palm of your hand on the person's forehead, use your thumb and index finger to pinch the nose closed. Now take a regular breath and seal your lips around the person's mouth, creating an airtight seal. Give one breath for 1 second. Watch for the chest to rise as you give the breath. If the chest doesn't rise, repeat the head tilt chin lift maneuver and try again. Give a second breath for 1 second while watching for the chest to rise. So far, we've learned what you should do when someone doesn't have a pulse, but you should also know what to do if someone clearly has a pulse but is not breathing normally, also known as agonal breathing. Agonal breathing may include gasps, snorts, snores, or groans. They may sound like this. These may appear forceful or weak, and some time may pass in between them. When that happens and the person has a pulse, rescuers should provide breaths without chest compressions. Breaths are needed most commonly for anyone in cardiac arrest from respiratory-related emergencies. For adults, give one breath every 6 seconds. Similar to CPR, you should give each breath for 1 second, making sure that each breath results in visible chest rise. For infants and children, give one breath every 2 to 3 seconds. Breaths are given slightly faster for infants and children because they are more likely to arrest because of a respiratory-related emergency. During breaths without compressions, check the person's pulse about every 2 minutes. Now let's practice what you've just learned. We'll pause here while you get into position. Another way to ventilate is with an advanced airway. Devices such as laryngeal mask airways, supraglottic airway devices, and endotracheal tubes are types of advanced airways that are more secure for providing ventilation. These devices help prevent gastric inflation and airway obstruction. Placing these devices requires special training that we won't cover in this course, but you should know how to give breaths when an advanced airway is in place. When you provide CPR to an adult with an advanced airway in place, the compression to ventilation ratio changes. Instead of providing cycles of 30 compressions and 2 breaths, you'll perform continuous compressions at a rate of 100 to 120 per minute, while another rescuer gives 1 breath every 6 seconds. In other words, when an advanced airway is in place, you won't pause compressions to give breaths. Not pausing compressions allows for adequate blood flow to the heart and brain. For infants and children, you'll perform continuous compressions at a rate of 100 to 120 per minute, while another rescuer gives 1 breath every 2 to 3 seconds. You may have heard of the opioid crisis. We use this term to express the severity and scope of a public health issue that affects millions of people and families around the world. Opioid overdoses are one of the leading causes of cardiac arrest in young people. In the United States alone, more than 2 million people have an opioid use disorder. Opioids are a highly addictive class of drugs that are primarily prescribed for pain relief. Opioids can be prescribed medications such as morphine, codeine, oxycodone, hydrocodone, fentanyl, hydromorphone, and buprenorphine. Opioids, such as heroin and fentanyl, can also be produced or obtained illegally. Many illegal substances are mixed with opioids, so someone might take opioids without even knowing. Opioids affect the brainstem, which controls a person's breathing. In high doses, opioids suppress the brain's natural drive to breathe, which causes respiratory depression, slows the heart rate, and can lead to a cardiac arrest. This hypoxic state can cause damage to the brain even before the person's heart has stopped beating. In high doses, opioids can cause abnormal breathing or cause a person to stop breathing altogether. This can lead to cardiac arrest. Naloxone is a medication that can reverse the effects of opioids and may restore normal breathing. Naloxone is commonly stored in a first aid kit or near an AED. It is safe to administer even if you're not sure what drug the person took. Naloxone can be given intravenously, intramuscularly, and intranasally. Given the potency of opiates, you may need to give someone a second dose of naloxone if a person doesn't respond within 2 to 3 minutes to the first dose. To administer naloxone nasal spray, hold the canister with your thumb on the bottom of the plunger and your pointer and middle fingers on either side of the nozzle. Insert the tip of the nozzle into the person's nostril. Now, press and hold the plunger to administer the entire dose. After you've emptied the canister, remove the nozzle from the person's nostril and discard the canister into the trash. Each canister contains only a single dose, so you'll need another canister to give a second dose. To assess if someone is having an opioid-associated emergency, consider the following. Is there any evidence of opioid use nearby, such as syringes, powder, or medication bottles? Has the person vomited? Are they unresponsive or hard to wake? Check to see if the skin is cyanotic. Are their fingernails or lips blue or gray? Is their skin sweaty? Are the pupils of their eyes very small? Any of these signs can point to an opioid-associated emergency. If you suspect an opioid-associated emergency in an adult or child, first verify scene safety and check for responsiveness. If they're not responsive, shout for help, call 911, and send someone to get naloxone and an AED. Next, check to see if they're breathing normally. If they're breathing normally, prevent further deterioration by tapping and shouting to keep them awake. Keep their airway open by repositioning their head and using the head tilt chin lift maneuver. Give naloxone and continue to monitor their responsiveness and breathing. After you give the first dose of naloxone, tap and shout to keep the person awake. If they are not alert but are still breathing, give a second dose of naloxone. If the person is not breathing normally, check for a pulse. Do not check for a pulse for more than 10 seconds. If they have a pulse, use the head tilt chin lift maneuver to keep their airway open and give breaths. Give one breath every 6 seconds and administer naloxone. For an infant or child, breaths should be given slightly faster, so you'll give one breath every 2 to 3 seconds. Do not delay breaths to give naloxone. If you're alone and don't have a phone, leave to call 911 and get naloxone and an AED if available. If you need to leave the person, put them in the recovery position. To do this, gently turn their head to the left, place their left arm at a right angle to their body, and put their right hand under their left cheek. Then bend their right knee and roll them onto their left side. This position will help prevent choking if they vomit. Once they're in the recovery position, gently open their airway by tilting their head back and lifting their chin. Check to make sure nothing is blocking their airway, and continue to closely monitor the person's breathing and level of responsiveness until medical help arrives. If the person is not breathing normally and does not have a pulse, start CPR, use an AED if available, and consider giving naloxone. Do not delay CPR to give naloxone. For further information on opioid-associated emergencies, please consult your provider manual. Treating cardiac arrest in someone who's pregnant can come with heightened anxiety because multiple lives are at stake. The best outcome for all depends on BLS rescuers summoning help, providing high-quality CPR, and using an AED without delay. Compressions, ventilation, and AED use are mostly unchanged. If the person is clearly pregnant, indicated by a visibly rounded abdomen, and additional help is available, rescuers should perform manual lateral uterine displacement. To do this, use one or two hands to manually shift the abdomen to the left. This is known as left manual displacement. The uterus is no longer resting on the major arteries and veins that supply blood to the heart. This will allow for more blood to flow during CPR. More information about how to perform left manual displacement is available in your provider manual. The World Health Organization estimates that there are about 236,000 deaths due to drowning worldwide each year. Significant efforts have focused on creating systems to prevent drowning, but an average of 4,000 fatal and 8,000 non-fatal drownings still occur annually in the United States, which is likely an underestimate. The drowning chain of survival can help you prevent drowning, respond quickly and effectively, and potentially save someone who is drowning. The first link in the chain is to prevent drowning. Preventing drowning starts with swim lessons, learning water skills like treading water, having pool fences, and wearing a U.S. Coast Guard approved life jacket, even if you are a strong swimmer. The next link involves recognizing a swimmer in distress so you can help. To help a struggling swimmer, first, make sure the scene is safe and shout for help.
Hey, are you okay?
Tell someone to call 911 and get the AED.
You, call 911 and get an AED.
Provide the struggling swimmer with a rope, pole, or flotation device to grab onto. The safest way to help a struggling swimmer is to remain out of the water yourself so that you don't become another person who will need help. Next, if you're able to do so without putting yourself in danger, move the person to shallow water, ideally in a flat position with their head above water or out of the water completely. Don't worry about clearing any water that the person may have breathed in. It's not necessary.
Are you okay?
If the person is not responding and not breathing, you'll need to open their airway by using the head tilt chin lift maneuver and then give 2 breaths. Keep in mind that someone who dove into a pool or water with hazards could have a head or spinal injury. If you are concerned about a possible injury, use the jaw thrust maneuver instead of the head tilt chin lift maneuver. If for any reason you can't give mouth-to-mouth breaths, give mouth-to-nose breaths instead. If the person has a pulse, continue providing breaths. Check the person's pulse about every 2 minutes. If the person is still not breathing and not responding, they may be in cardiac arrest. If the person has no pulse, start CPR immediately and use an AED as soon as one is available. Now that we've covered adult BLS, let's discuss BLS for children. It may be difficult to imagine a child going into cardiac arrest, but it happens. A child is defined as anyone from 1 year of age to puberty under the AHA BLS guidelines. Signs of puberty include chest or underarm hair on boys and any breast development on girls. For those with signs of puberty and beyond, adult BLS guidelines should be followed. In adults, the cause of cardiac arrest is often cardiac-related, but in infants and children, cardiac arrest is often due to respiratory failure or shock that reduces the oxygen content in the blood. As a result, giving chest compressions alone does not deliver oxygenated blood to the heart and brain as effectively as giving both compressions and breaths. That's why it's so important that infants and children receive both compressions and breaths during high-quality CPR. Other common causes of cardiac arrest in children and infants are choking, anaphylaxis, and drowning. If a child is in cardiac arrest, verify scene safety, check for responsiveness, shout for nearby help, and activate the emergency response system. Next, simultaneously check to see if the child is breathing normally and has a pulse to help you determine the next appropriate actions. You can check for a pulse in the carotid or femoral artery for a child. To perform a femoral pulse check, put 2 fingers in the inner thigh midway between the hip bone and the pubic bone, and just below the crease where the leg meets the torso. Then press the fingers to attempt to feel for the pulse for at least 5, but no more than 10 seconds. If the child is not breathing and there is no pulse, start high-quality CPR. Quickly move bulky clothing covering the child's chest out of the way so that you can locate the appropriate hand placement for chest compressions. Because you will not need to push as hard, the technique for delivering compressions on a child differs slightly. You can use the heel of one hand or use 2 hands like you learned for adult CPR. For one-handed compressions, place the heel of one hand in the center of the chest on the lower half of the sternum. It doesn't matter which technique you use as long as you are able to provide deep, effective compressions. The depth of compressions will be slightly shallower for children because their chests are smaller. Your compressions must go to a depth of at least 1/3 the diameter of the child's chest. That's approximately 2 inches or 5 centimeters. The rate for chest compressions is the same for adults, children, and infants, which is 100 to 120 per minute. Now let's talk about providing breaths to a child. Give breaths with a barrier device such as a pocket mask or face shield, or use a bag mask device to deliver ventilation to a child. Ventilating a child by using a bag mask device is similar to adults, but the masks for children are smaller. It's important to note that giving breaths to children requires less volume and force than giving breaths to adults. Breaths that are too large or forceful have greater potential to cause lung trauma in children than in adults. However, you still need to provide enough air to see the chest rise. Finally, the compression to ventilation ratio for child CPR is the same for adult CPR when you are the only rescuer. If you are alone, perform cycles of 30 compressions and 2 breaths. If you have a second rescuer and the child is pre-puberty, perform cycles of 15 compressions and 2 breaths. Always use the AED as soon as one becomes available to you. Turn on the AED and follow the prompts. We will see how this works in the next section. Now that you know the basics of child BLS, let's discuss how you would respond in an emergency. If the child is breathing normally and a pulse is felt, monitor until emergency responders arrive. If the child does not have normal breathing and a pulse is felt, give 1 breath every 2 to 3 seconds, or about 20 to 30 breaths per minute. After 2 minutes, assess the pulse for no more than 10 seconds. If the heart rate is less than 60 beats per minute, start CPR. If the heart rate is 60 beats per minute or greater, continue giving breaths and check the pulse every 2 minutes. If no definite pulse is felt, start CPR. If the child is not breathing or is only gasping and a pulse is not felt, you need to start CPR. If you are alone and did not witness the sudden collapse of the child, you should perform 5 cycles or 2 minutes of 30 compressions and 2 breaths to deliver oxygenated blood to the child's brain before you leave to activate the emergency response system and get an AED. Be sure to return quickly to resume CPR and use the AED. If you're alone and witness the sudden collapse of a child, leave the child to go activate the emergency response system, if not already done, and get an AED. Then return to the child to perform CPR and use the AED as soon as possible. For many healthcare professionals, a 2-person or team rescue is more common. If you have help and you are working with another rescuer to perform CPR on a pre-puberty child, you should provide cycles of 15 compressions and 2 breaths. This prioritizes ventilation because pediatric arrests are more commonly due to respiratory causes. Remember, for children showing signs of puberty, you would provide cycles of 30 compressions and 2 breaths. Let's see how 2-rescuer child BLS works in the following scenario.
I had to send Emma home a little bit early. She was feeling kind of nauseous. And Jackson, I want to remind you, he'll need a new inhaler before that big field trip. He has very bad asthma.
Well, that's a good idea. There's a lot of... Ben? Ben!
The school nurse assesses the scene for safety and checks for responsiveness.
Hey, are you okay? Are you okay? Call 911 and get an AED.
He doesn't respond. He's not breathing normally, and he doesn't have a pulse. She starts cycles of 30 compressions and 2 breaths until help arrives.
4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 7, 8, 9, 10,
We're here to help.
12, 13, 14, 15, 16, 17. He collapsed and was unresponsive, so I started CPR.
Hey, are you okay? Are you okay? He's in cardiac arrest.
Send additional personnel for
2,
confirmed
3,
cardiac
4,
arrest.
5, 6,
Apply pads
7,
to
8,
patient's bare
9,
chest.
10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22.
Plug in pads connector.
23, 24, 25, 26, 27,
Do
28,
not
29,
touch the
30.
patient. Analyzing heart rhythm.
Clear.
The monitor defibrillator is now analyzing the person's heart rhythm and will advise if a shock is needed.
Shock advised. Charging. Stay clear of patient.
Clear.
Make sure that no one is touching the patient before the shock button is pressed.
Deliver shock now. Press the shock button now. Shock delivered. Start CPR.
1, 2, 3, 4.
Plan to switch
5,
roles as the
6,
compressor
7,
every
8,
2 minutes,
9,
or
10,
sooner if the
11,
compressor is
12,
fatigued.
13, 14,
Switching roles should take no more than 5 seconds to minimize interruptions in chest compressions. Continue providing CPR and following the prompts until advanced life support providers take over or the child starts to move.
13, 14.
To provide compressions on an infant, there are 2 options. You can use the heel of one hand or the 2 thumb encircling hands technique. We will review both techniques and then you'll have a chance to practice. To use the heel of one hand, place the heel of one hand on the sternum or breastbone, in the center of the infant's chest, just below the nipple line. Be careful not to press on the bottom of the sternum or breastbone. To use the 2 thumb encircling hands technique, place both thumbs side by side in the center of the infant's chest, on the lower half of the sternum. The thumbs may overlap in very small infants. Encircle the infant's chest and support the infant's back with the fingers of both hands. If you can't get your hands around the infant's chest to perform the 2 thumb encircling hands technique, provide compressions with the heel of one hand instead. Whichever technique you use, be sure that you're able to push hard and fast to a depth of at least 1/3 the diameter of the infant's chest, or approximately 1.5 inches or 4 centimeters. Compress at a rate of 100 to 120 per minute, and after each compression, allow the chest to recoil completely. Always count out loud as you perform compressions. Now that you know how to provide infant chest compressions and ventilations using a bag mask device, let's move on to 2 rescuer infant BLS. Before we practice, there are a couple of key things we need to note. In 2 rescuer infant BLS, you should use the 2 thumb encircling hands technique. However, if you cannot perform adequate compressions with the 2 thumb encircling hands technique, you should use the heel of one hand. The other key difference between 1 rescuer and 2 rescuer infant CPR is the compression to ventilation ratio. Similar to CPR for a child with 2 rescuers, use a ratio of 15 compressions to 2 breaths. Let's see how 2 rescuer infant BLS works in the following scenario.
Daniel? Daniel! Hey, are you okay? Are you okay?
The infant isn't responding or breathing. Dad calls 911 and puts his cell phone on speaker mode.
My baby's not waking up.
The 911 telecommunicator will instruct him to start CPR with compressions and breaths until EMS arrives.
7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 21, 22, 23, 24,
Sir,
25,
we're here to help.
26.
EMS arrives and verifies scene safety.
I don't know what happened. My baby wouldn't wake up, so I called 911 and started CPR.
Hey, are you okay? Are you okay?
They confirm that the infant is unresponsive and is not breathing normally. They perform a brachial pulse check and confirm that the infant does not have a pulse.
He's in cardiac arrest.
Send additional personnel for confirmed cardiac arrest.
5, 6, 7, 8.
Apply pads to patient's bare chest.
The first rescuer should take over CPR from the dad immediately, including chest compressions and ventilations. It's important to count out loud while delivering chest compressions so that the second rescuer knows where you are in the CPR sequence.
Plug in pads connector.
1, 2, 3, 4, 5, 6, 7, 8.
Do not touch the patient. Analyzing heart rhythm.
Clear.
The monitor defibrillator is now analyzing the infant's heart rhythm and will advise if a shock is needed.
Shock advised. Charging. Stay clear of patient.
Clear.
Make sure that no one is touching the infant before the shock button is pressed.
Deliver shock now. Press the shock button now. Shock delivered. Start CPR.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Plan to switch roles as the compressor every 2 minutes, or sooner if the compressor is fatigued. Switching roles should take no more than 5 seconds to minimize the interruptions in chest compressions. Continue providing CPR and following the prompts until advanced life support providers take over, or the infant starts to move.
Choking happens when something blocks a person's airway. In a severe airway obstruction, the person usually has signs of poor air exchange and difficulty breathing, such as a silent cough, an inability to speak or breathe, or cyanosis. That is, blue or gray coloring of the lips, nail beds, or skin. To relieve choking in a responsive adult or child, you'll perform 5 forceful back blows followed by 5 abdominal thrusts. You should also activate the emergency response system in case the person becomes unresponsive. If someone indicates that they're choking and can't talk, you must take action. Adults or older children who are choking may clutch their neck with both hands, making the universal choking sign. For an adult or child who has signs of severe choking, ask them, "Are you choking?" If they nod yes and cannot talk, a severe airway obstruction is present, and you need to take steps immediately to relieve the obstruction. Perform 5 back blows using the heel of your hand and forcefully strike the person's back in between their shoulder blades. If back blows do not relieve choking, perform 5 abdominal thrusts. Grasp your fist with your other hand and press your fist into the person's abdomen with a quick, forceful upward thrust. Give each new thrust with a separate, distinct movement. Continue alternating 5 back blows followed by 5 abdominal thrusts until the object is dislodged or the person becomes unresponsive. You should make sure they are seen by a healthcare professional even if they are able to clear the object on their own. If the person is larger, visibly pregnant, or in a wheelchair, and you can't get your arms around them, you will perform chest thrusts instead of abdominal thrusts. Put your arms under their armpits and place one fist, thumb side, in the middle of the chest on the lower half of the breastbone. With your other hand, grab the fist. Pull straight back to give chest thrusts instead of abdominal thrusts. If the person becomes unresponsive, gently lower them to the ground, shout for help, and activate the emergency response system if no one has already done so. Begin CPR with chest compressions. Do not check for a pulse. Perform CPR as usual, but with one difference. Each time you open the airway to give breaths, open the person's mouth and look for the object. If you see an object that looks easy to remove it with your fingers. Don't perform a blind finger sweep because this may cause the object to become lodged farther back in the airway. If you don't see an object, continue CPR. If the person choking is already unresponsive when you arrive, you probably will not know if a foreign body airway obstruction exists. In this situation, you should activate the emergency response system and start high-quality CPR. Choking is also a common emergency in infants. The steps to relieve choking in an infant are similar to those for adults and children with a few key differences. First, don't use abdominal thrust on infants. If you find an infant who's choking but is still responsive, activate the emergency response system. Kneel or sit with the infant in your lap. Hold the infant face down with the head slightly lower than the chest, resting on your forearm. Support the infant's head and jaw with your hand. Avoid compressing the soft tissue of the infant's throat. Rest your forearm on your lap or thigh to support the infant. With the heel of your other hand, deliver 5 forceful back blows between the infant's shoulder blades. Deliver each back blow with sufficient force to attempt to dislodge the object. After delivering 5 back blows, place your free hand on the infant's back, supporting the head with the palm of your hand. This will cradle the infant between your 2 forearms, with the palm of one hand supporting the face and jaw, while the palm of the other hand supports the back of the infant's head. Turn the infant over while carefully supporting the head and neck. Hold the infant face up with your forearm resting on your thigh. Keep the infant's head lower than the trunk. Provide 5 quick downward chest thrusts with the heel of one hand in the middle of the chest, over the lower half of the sternum. Deliver chest thrusts at a rate of about 1 per second, each with enough force to dislodge the object. Repeat the sequence of up to 5 back blows and up to 5 chest thrusts until your actions have removed the object or the infant becomes unresponsive. As with an adult, if a choking infant becomes unresponsive, shout for help and activate the emergency response system if no one has done so. Place the infant on a firm, flat surface and begin CPR. If you're alone and have no access to a phone, perform 2 minutes or 5 cycles of CPR before you leave or carry the infant with you to activate the emergency response system. To give breaths for an infant who's choking, the mouth-to-mouth and nose technique is preferred. If you can't cover the infant's mouth and nose with your mouth, use the mouth-to-mouth technique instead. To give mouth-to-mouth and nose breaths, start by opening the infant's airway with the head tilt chin lift maneuver and look into the mouth for the object. Next, place your mouth over the infant's mouth and nose to create an airtight seal. Give 1 breath, blowing for about 1 second. Watch for the chest to rise as you give the breath. If the chest doesn't rise, repeat the head tilt chin lift maneuver to reopen the airway and try to give a breath that makes the chest rise. Each time you open the airway to give breaths, open the infant's mouth and look for the object. If you see an object that looks easy to remove it with your fingers. Never perform a blind finger sweep because this may cause the object to become lodged farther back in the airway. Now let's practice choking relief on an infant. You'll perform 5 sets of back blows and chest thrusts. Follow along with the video. Here we go in 3, 2, 1.
1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5.
The AHA thanks you very much for your time and attention, and especially for your commitment to maintaining the critical life-saving skills of BLS. We appreciate and honor the important work you all do as healthcare professionals and emergency responders. The AHA is always here to support you, so please revisit the course materials anytime you need a refresher. And remember to practice your BLS skills periodically.